I'm coming here today in front of you as a psychiatrist who works with ADHD in adults, but also as a mother of children with ADHD. So there's definitely that part of lived experience and parenting that might influence some of the emphasis that I will do throughout the presentation. And the emphasis is strengths-based approach and not deficit-based approach, as sometimes the medical model teaches us. So that'll be my bias up front, and just kind of, I'll start the presentation and be mindful of time. All right. So just, okay, and I have to go over just the basic disclosure. My relationships that I have to disclose to, so you know where my bias might come in. I currently do not have any grants or research or supports at this time. I have done speaking engagements with Takeda, which is the maker of Vyvanse, one of the stimulants used for ADHD, and Synovian, which is the maker of Latuda, one of the medications we use in bipolar and mood disorders. I have gotten paid through consulting fees through Triumph, which is an educational company that I co-own with occupational therapist. I do not have any patents at this time. I've also gotten paid through Ontario Medical Association with my leadership and administrative involvement. I do insurance assessments through various companies for third parties, as well as coaching and leadership that is outside of medicine. And again, just to disclose that this program, ECHO, has received financial support from the Ministry of Health and Long-Term Care in the form of an annual funding agreement. The program has received some in-kind support from CAMH and Unity Health in Toronto of clinician time and logistical support. And again, the conflict of interest, you know, I don't have any payment for this presentation, but as mentioned in the previous slide, the conflict of interest would be perceived because I have gotten paid work from Takeda, the maker of Vyvanse, one of the medications used for ADHD. Okay. Again, the information presented in the CME is based on the recent information that is evidence-based. The CME and its material is peer-reviewed, and all the recommendations involving clinical medicine are based on evidence that is accepted within the profession. And all the scientific research referred to, reported to, or used in the CME activity and justification of patient care conforms to generally accepted standards. Okay, so it's evidence-based. And it's important because evidence changes all the time. There's updates coming in the fall. So things I might teach you today might be slightly different in the fall after the CADRA conference in the fall. The other important disclaimer, you know, we're not providing any particular treatment, medical, or personal legal advice for any individual situation or patient. This is educational and general information purpose. It's very introductory level because there's time constraints, and this is a very vast field. And again, if you're experiencing any mental health distress during this presentation, please see your healthcare provider or emergency department. As I mentioned before, sometimes people very much relate or get triggered by the information presented because it's very relevant in their personal life or family life. And that is a reaction that is valid for some people, and they do need to address it with their own healthcare provider. We are not able to address it in this session. All right, so today we are going to be focusing on ADHD kind of management and treatment. Number one objective is going to be understanding ADHD, that it is a chronic condition that is present 365, 24/7. And so kind of adjusting your expectations for treatment and management. We'll talk about medication approaches and the non-medication approaches. ADHD is a neurodevelopmental executive function condition. It is there all day, every day of the week, every year of your life, right? It is a literally 365, 24/7 condition. It doesn't just stop. It doesn't take a break when somebody's on vacation. It doesn't take a break during summer holidays, which again, we used to think that people in the past, we used to think that children in the summer should take a break or on the weekends or whatnot, but no, it's there all the time. The impairments or the difficulties will vary on other factors, but this condition's there all the time. And understanding it as a 365, 24/7 condition is really important when we try to support our patients and clients, or we try to troubleshoot treatments or even address treatments, right? Because it might be different what you're targeting when somebody's on vacation versus at work versus summertime. And just to understand all the domains that are affected and why it's a 365, 24 condition. So when we start with ADHD treatment, the treatment has to be multidisciplinary, meaning there's not one single thing that is going to fix ADHD, okay? Multidisciplinary meaning that there has to be involvement of physicians, therapists, potentially coaches, client supports, case managers, accommodation specialists, coaches. So it's multidisciplinary. It's unrealistic to be fixed by a psychiatrist or family doctor alone or just one clinician. Not realistic. Naming the condition, like the diagnosis in itself, is step one, because it gives people kind of like a roadmap to what they need to do, what are the areas that they might need to address. It takes away some of the shame that they might have assumed was, their personality issue or moral failures, to wait, this is actually a real condition. And how do I need to manage? What do I need to manage? So the diagnosis in itself is very validating, gives direction, gives guidance, and like what to expect in the future, how to cope now. Another key part of actually treating ADHD is education, because there's just so much misinformation. There's so many myths. There's so much focus on deficits. So having very reasonable, wholesome approach to telling patients about what ADHD is and isn't, whether it's about treatment options, whether it's about, what their day-to-day looks like, is key. Having valid evidence-based information, not things that are just out there, myths, judgments, and stigma, because that often interweaves into what people think ADHD is, and towards themselves, towards their children, towards, colleagues around them with ADHD. There is no fix or cure. We don't fix ADHD. We don't cure ADHD. We can't. We don't do that, right? So that, again, part of psychoeducation, part of our understanding as a clinician, that we cannot fix ADHD. People sometimes come in with unrealistic expectations that we're going to fix things. It's like, no, we can't fix. We don't fix this, right? Again, another part of managing ADHD is understanding how ADHD might present across a lifetime for somebody and why people present with this issue at this point, or even anticipating issues at transition points, like transition to university or college, transition into parenthood, and supporting our clients and patients about that, or anticipating that they're going to come with those difficulties, right? Again, the intergenerational component, if you're treating the child, is the parent getting the support? Because if the parent isn't, it's very hard to manage the child's treatment if the parent is struggling with ADHD. And it's very common for me to get referrals from pediatricians of the children that they're treating. Not direct, but they will mention to the parent that, hey, you probably should get assessed, and then they will get referred by their own doctor, right? Again, we also have to understand any changes, new roles, functional changes, loss of support will unmask difficulties for people, right? And this is where I can't pronounce it ever, YFERS is helpful for functional understanding, because what people might struggle with today might be different 6 months from now or 2 years from now. So we do have to understand, what are they struggling? What are we treating? Because we're not just treating ADHD as the label, it's what are your struggles today? What has changed? So those are some of the questions that I hope we're asking and focusing when we're talking about treatment, because we need to have these questions to guide the roadmap of treatment. And I tell people, it's kind of like GPS. We might be taking one route today, but we might encounter difficulties along the way, and we have to change our route and our roadmap, and that's okay. But treatment of ADHD isn't going to be, I'm coming from A to B, and that's it. And you're B, you get there, it's all fixed. Life does not work like that. Neither does ADHD treatment. There's going to be setbacks, medication side effects, other environmental issues, and having a roadmap helps us manage whatever other things that might develop along the way. So this is why I really work on this foundation: chronic neurodevelopmental condition. What's the problem today? What can we do from a multidisciplinary approach? Not from one, not from fixing. Okay. Again, this is a model I discussed last week about the transition model, that it's better to understand ADHD in a life transition model rather than in, this is a disease or this is what it is. When there's transitions, people will struggle. If there's more cognitive demand and expectations, people might struggle. Okay. This is what ADHD might look like across the lifespan. This is from the last presentation, and I'll leave it here just so it's available. This is a diagram I often use, and I often will get my patients to work with me. This is not a scientific calculation, but this is more conceptual kind of way of visualizing what one's day looks like, right? This is an average adult function. You probably wake up at 7, from 7 to 5. Usually, you might be managing kids, parenting, you might be working, you might be studying, you're driving. If you have a driver's license, you're usually driving. You might be going to your appointments. You might be managing your medications, having to take medications and whatnot. You might have to do your groceries and meal planning. You have to deal with phone calls and emails and whatnot, and social interactions. All of these are affected by ADHD significantly, right? And so we have to understand what might be affected during the day versus what they do in the evening, where again, they're transitioning to parenting, food prep, driving, studying, household responsibilities, bedtime for the others and themselves, for kids, versus late evening. Again, many people don't go to bed at 9 o'clock. Our life doesn't allow that. Many people are catching up on work after 9. Many people are doing, cleaning, planning the next day, time when their partners, binge eating, or social media, right? Or sleep issues. So I get people to draw or label what are the cognitive tasks, or what are things they do in their day, and what are the issues that they're encountering, because we need to understand what are we trying to address, and how are we trying to address it. And we need to use the language that is relevant to our patients, so probably terminology at, probably grade 5 level, so that people can actually understand what we mean by cognitive demand or tasks, what they're doing, rather than the language you might find on the questionnaires or in the DSM-5, because those are two technical terms, right? But asking, okay, what's happening? Are you working? Are you studying? How are you doing with that? How's your driving? Because again, ADHD affects that. ADHD affects attention, impulsivity, road rage, all of that. So by looking at all of this around their 24 hours, we might get an idea what we need to address, what is the priority, especially if there's safety concerns, like driving in particular, right? Versus other issues. How are they managing their health? Because if they're missing appointments, if they're not medication adherent, that's a big issue, right? And that might be first things we have to address versus something else. So kind of putting it out like this helps you to understand the depth of their issues, and also what are the priorities that are safety driven? What are the priorities for the patient? What are actually priorities that are possible? Because we might say, hey, you should address this first, but that's not what's possible because they don't have the money for that. They don't have the opportunity for that. And so we do have to work with what is possible for the patient to address in these difficulties. So again, what interventions may be needed across life? As you could see, a lot more things that may be needed, and medications might be needed across the lifespan. Social skills, relationship skills. You see me highlighting consent over here. That's part of social skills. And consent may involve consent in sexual interactions, consent in just, sharing somebody's information, work-related information, consent in touching somebody. Might not be sexual, but, somebody might want to touch somebody and it's perceived as harassment or crossing a physical boundary. That is a big thing. Part of social skills is consent in so many settings from another party that might be affected in somebody with ADHD because of impulsivity, or just, kind of that not that good of understanding of boundaries, right? And that can cause people legal charges, including sexual interactions, right, or physical touch. So there's a lot of things that, you see across the lifetime that we have to support. Unfortunately, in our current system, we don't have supports for adults for all of this. We might have supports for children, yet you see the demand for supports increases, yet we don't have it. And as you could see, parent-child supports and parenting coaching could be very crucial. Accommodations, online behavior, we have to be very, very attentive to that, because people, again, might say things or do things impulsively that could cost them jobs, cause legal problems, or put them at risk of, sharing personal information on, let's say, Twitter or whatever else. So these are things we have to, be really aware of. Driving safety, financial management is a big one. time management, and health management, attending to their appointments, medication adherence, big things in transition age and adulthood, because, they have to make their own appointments, right? They have to follow up, or we don't rely on their parents or other supports for that, but these are big things to consider. So medication, I am going to be brief on this because it's very detailed, and CADRA guidelines has a very clear table to follow for prescribers. So when we talk about medications, things we have to consider is, first of all, they have to be evidence-based. We can't just give whatever. CADRA guidelines has a nice table, a nice summary. We do have to consider comorbidities that might prevent us from giving medications, particularly heart issues, high blood pressure, any other active medical issues that might be monitored or considered. There isn't really a true contraindication to the stimulants. You could potentially give people medication if they have blood pressure problems, as long as you collaborate with their internal medicine or cardiologist, and you kind of have that joint plan, you discuss the risk and benefit, you monitor, because again, you have to look at what's the risk of untreated ADHD versus not. Pregnancy state, are they planning to get pregnant? Are they pregnant? Those are things that will influence medications. But again, it's not an all or nothing approach. It's more about looking at individual risk, who's monitoring, what is important, what's the risk of being unmedicated, right? Cost is a big one, because there are certain medications that are not covered, or people don't have coverage. They have a job, but there's no benefits, they're self-employed. So cost is a big one to consider when we talk about medications. What's the adherence like? Are they able to adhere? Are they forgetful? Anything else we have to suggest? Again, first line are usually long-acting stimulants, atomoxetine, off-label, meaning that these are not medications approved for ADHD alone, but could be helpful, would be bupropion, which is antidepressant, clonidine, and guanfacine, which is used in children. In adults, it hasn't been officially approved, but extremely beneficial. And these are some other medications that, again, could be useful. So I'll leave it as that because of the time consideration, and the CADRA table really gives a nice visual representation of this. Now, in terms of, people will have questions. Again, I'm not going to have this fully read, but there's the details. What if I start my children on stimulants? They're going to be addicted to cocaine or crystal meth. That's not what the evidence shows. On the contrary, if we start treating the children earlier, they're less likely to go into using the stimulants later. If they start treating children later and for shorter, they're more likely. Again, this is something that parents will worry about. Again, reasonable worry, but we have to look at the facts. You will have the reference to this review, so you could take a look at it in more detail with all the details on it. In terms of medications and bipolar disorder, again, many people get very anxious about treating. Many people have stigma and misunderstanding about this. The comorbidity, or the times that ADHD and bipolar runs together, is quoted between 20% to 50%. So there is 20 to 50% overlap that a person could have both, right? So it's huge. It's a huge comorbidity. And the reality is, again, I talk to my patients, look, ADHD is there every day. Bipolar disorder, there's episodes, right? And, if people have ADHD that's untreated, they literally might struggle to take their bipolar medications or make it to their appointments, because that's an everyday condition that's going to affect them. So we do have to look at risk and benefit. And if they are treated for bipolar on a mood stabilizer, there is no evidence of, a manic episode triggered by methylphenidate medication. There isn't as much information about the mixed salts-based medication like Vyvanse and whatnot, but we do have to consider the risk of untreated ADHD, and we cannot be afraid of mania or hypomania if the person is stabilized, right? And again, it's a risk and benefit. And sometimes I will see psychiatrists who are like, oh my God, this person's on this medication and they got triggered with, this and whatnot. Well, they did. Yep, we know that can happen after they're stabilized. Again, let's look at cost and benefit of treating ADHD, because we still have to address ADHD. We can't just take off the medication and let them be without anything, because their untreated ADHD could cost them a job, could cause a driving accident, could impact their parenting. So we do have to consider that, even if they had a manic episode and they were on the stimulant. Okay, what are we going to do to address your ADHD otherwise, if we're not going to be using the same medication, or if we try to understand what else might be there? Because too often ADHD gets lost after we stabilize the bipolar. we emphasize bipolar, but we forget that, they still have to manage everyday life, and ADHD affects that. Cannabis and ADHD, very common question. Cannabis is not a treatment option in CADRA guidelines. So remember the disclosure I started at this presentation. We are focusing on evidence-based treatment. And currently the evidence-based treatment is dictated by CADRA guidelines that are the Canadian ADHD guidelines here in Canada. That might change down the road, but today, as of August 2023, cannabis is not in the guidelines as treatment for ADHD. And I know patients will come in and say, oh, but my friends are using it, or it's the best thing ever, or this is what helps me. Just because somebody feels it helps them doesn't mean that it is evidence-based treatment. And I know there's a question, folks can get it prescribed medically. I can't comment on other physicians' prescribing patterns or what they do or they do not do. I can tell you what's the evidence, and it's not in the CADRA guidelines. I follow the CADRA guidelines. So, and again, when people tell me, oh, but it makes me feel better. Well, you know what? Alcohol makes people with anxiety feel better. It doesn't mean that we prescribe it. Opiates can make people feel better for pain. It doesn't mean that it's indicated for that type of pain. So just because people have a perceived benefit does not mean that it's actually evidence-based treatment, or it's actually healthy, sustainable, or doesn't have potential for addiction or whatnot. So we have to be very careful in terms of how we look at cannabis and ADHD. And again, if you look at the review, right here, they will talk about in more detail about that, we still don't understand fully the impact of cannabis on, neurodevelopment of young adults, and that people with ADHD, the more severe the ADHD, there is greater risk of cannabis use. Cannabis is the most abused substance by people with ADHD. So there's clearly some sort of link between cannabis and ADHD that we don't fully understand at this point. At the same time, the risk of addiction with cannabis, is quite high for people with ADHD. So we have to be very careful about normalizing or prescribing it as treatment, especially when it's not in the CADRA guidelines. And there's very limited evidence overall about cannabis and ADHD and the benefit of it, okay? I don't know how other people prescribe. I can't comment on that. I can only comment on evidence, and that if I see patients who are struggling with cannabis use and they use it all day, every day, really harm reduction. Would I start somebody on a stimulant where they're using a ton of pot? No, because we need to address the most acute issue, because cannabis in itself can cause symptoms that look like ADHD, right? And so again, usually looking historically, you can elicit symptoms that will satisfy the DSM criteria for ADHD diagnosis. So you can do that with good history and collateral. And the Wender-Utah scale is useful in that. But, again, if somebody's using heavy amounts of cannabis, we do have to work on harm reduction, reduce that before we consider, stimulants and whatnot. And it is a very complicated issue now that cannabis is also legal in Canada, right? So sometimes patients will say, well, it's legal. It's not, it's not an illegal substance. And so is alcohol, but we will address alcohol harm reduction if somebody's drinking heavily before, we would consider stimulants and whatnot. So it's still a very developing area, and something you have to pay attention continuously with any updates, because there is a lot of development happening in that area. All right. Non-medication approaches. I'm going to emphasize these a lot because I don't think they're emphasized enough. Cognitive behavioral therapy is in CADRA guidelines, very established for ADHD, particularly teaching skills, organization skills, procrastination, lots of work on cognitive errors that people with ADHD often have because of their life experiences. DBT skills are a new developing application for ADHD, and I'll tell you a bit more about that in a few minutes. ADHD coaching and skills training. So again, that's a very important aspect of mentioned ADHD. Skills training is like social skills, organizational skills, sometimes even relationship skills is what part of, teaching people these crucial skills. Work and school accommodations are absolutely crucial to scaffold somebody and to help them be successful in schooling or employment. And again, those could be very different between two people. So we can't just assume that what works for one person will work for another. Example could be, some people with ADHD need a bit of white noise in the background to focus, and they might be fine working in an open office space, and other people need complete silence to focus. So being in an open space could be extremely distracting, and they might need either closed space or noise canceling headphones. So that's, a big thing. Physical activity and exercise, very helpful. We recommend that in children a lot. Michael Phelps is a famous Olympic swimmer. If you look at his story, there's been interviews and whatnot that his mother put him into swimming to manage his ADHD. So again, physical activity is very crucial. Physical activity is crucial for managing some of the hyperactivity. It can also be very helpful for inattentiveness. There's a limitation. I forget exactly what's the quoted number of minutes that you can have the improvement in concentration after 30 minutes of physical activity. But Dr. John Ratey out of Harvard is a psychiatrist who does a lot of work in this field. And he's written a book on it if you want to look him up, on physical activity and exercise. Parenting skills and parent training is huge for managing ADHD, whether the parent has ADHD or both, because again, raising a child with ADHD could be very difficult for a parent, and there could be a lot of misunderstanding, judgment, stigma, frustration, and abuse. Parents could get really frustrated with kids with ADHD. They could yell, hit, call names, because it's extremely frustrating and draining. There's also grief and sadness, and a lot of issues with, parenting sometimes is other people judging your kid and completely not knowing what ADHD is, and either blaming the parents or telling the parent what to do when they are really trying the best they can to manage their child. So that's a big thing. And parent training on how to actually potentially intervene with the child's deficit and how to support the child. So there's different facets of parenting skills and parent training, let alone if the parent has ADHD and the child has ADHD, and the parent might get triggered by the child's ADHD behavior, often noise. If a child with ADHD makes a lot of noise, that could be very triggering for a parent because they could get distracted. They could come off as angry and dysregulated towards the child. The child might perceive that as, traumatizing experience and abuse. So there's often this big dynamic that has to be addressed for the benefit of both the parent and the child. Couples therapy and relationship skills are huge. People with ADHD are at greater risk of relationship abuse because, again, their ADHD symptoms could be easily used against them. At the same time, the partner in a relationship with somebody who has ADHD might feel burnt out, frustrated, resentful, because they might feel like a parent rather than a partner. So there's relationship kind of issues and partner burnout. So we have to kind of be aware of that. I really cannot emphasize enough the power of occupational therapy for people with ADHD. Occupational therapists can support people in skills training, accommodations, understanding individuals' deficits and strengths. So really important to have occupational therapy if we can. Now, in psychotherapy, these are very important targets. Shame. People with ADHD have a ton of shame because they actually have real evidence of failures, whether it's comments from others, whether it's losing jobs, whether it's missing things, failing things, right? Relationship losses. So there's a lot of shame and guilt. People with ADHD might also have experienced trauma because, some of the risk-taking behaviors, or because they might have ended up in abusive relationships, or because they were, difficult to parent children and they might have been abused more, whether it's, hitting, emotional abuse, called stupid. There might have been bullying from peers because peers might have, found them to be annoying or frustrating. There might have even been abuse from teachers who might have found them to be very frustrating as students to have. There's lots and lots of low self-esteem, low confidence, self-acceptance. There's lots of cognitive errors. They think all or nothing, like it's either going to be good or I'm going to be a complete failure. There's a lot of personalizing. It's my fault this happened. It's all my fault. It's because I showed up late. I lost this job. And again, unfortunately, they do have evidence for that, because if you do show up late, you likely will lose your job, right? So then they just personalize everything. And so there's a lot of cognitive errors to work with when we do therapy with people with ADHD, tons and tons. In terms of DBT and ADHD, this is a big thing that I'm very interested in. And, DBT, dialectical behavioral therapy, targets 4 areas: mindfulness, distress tolerance, interpersonal skills, and emotional regulation. And it's huge because mindfulness is very important. And there is evidence for mindfulness in helping ADHD. Again, not fixing and curing, managing. And, part of DBT is accepting opposites, right? Opposites could be true at the same time. And this is how I look at ADHD when I talk to my patients with it. We accept that you have ADHD, and what are we going to do to manage it, right? Whether that includes building up your self-esteem, learning skills, asking for accommodations, and sometimes having to walk away from things like, whether jobs or relationships that are not supportive of your difference, right? And so a DBT really nicely kind of summarizes that we accept that this is, really difficult, and we do have to change. There's no excuses. We can't just say, well, you have ADHD, that's it. No, we're going to validate, and we're going to work together on change that you need in your life. And, it's non-judgmental, it's validating, and there is expectation of change. So that's why DBT, I find, is a very, very good fit for people with ADHD, and focusing on building a life worth living, because, what that might be for one person with ADHD might be very different from somebody else. And so helping them kind of, assert that and even figuring out what works for them is really important. Mindfulness Prescription is a great book by psychiatrists out of UCLA in the US. And there's now quite a few workbooks that looks at DBT skills for ADHD and autism. I actually saw several when I looked at Amazon the other day. So you might want to look at that. And this was just one of the references. You could look, this is treatment as usual. So again, they use DBT-based groups versus treatment as usual. And there was improvement. So you could take a look at that for more details. Imposter syndrome is huge in ADHD because, especially in people with high functioning, ADHD. So these are your kind of professionals potentially, because they feel like they can't predict their function. They've made mistakes that people would think are stupid. They are having consistent performance, and they're just constantly anxious and overwhelmed, and constantly feel like they have to cover up and overcompensate, and they feel like never good enough. This is actually straight from the Cadre guidelines on imposter syndrome. And realistically, from my clinical experience, when I see imposter syndrome, many times it's either ADHD or trauma or both. But many times it's in high functioning people with ADHD that was, missed all along, and they have such significant insecurity because they can't predict their function. They might be making mistakes that people might say are stupid, especially the higher they go up in any leadership or career position, the more embarrassing and the more damaging some of these ADHD-related issues can be for them. This is a big resource I wanted to share. Again, I have zero benefit from this. There's 2 psychiatrists in Toronto who do groups for parents with ADHD. It's the referral. It is OHIP covered, and you can be anywhere in Ontario. And telecbt.ca actually has a couple of family doctors who do therapy that is OHIP covered, and they do some therapy for ADHD. If you look on their referral form under OHIP covered services, it is there if people want to make referrals. Referrals have to come from physicians. So I really wanted to share these are Ontario specific resources that do not cost money.